Yes, good afternoon. So today I'll be presenting challenging and unusual intraocular and intraorbital foreign bodies. I have no conflict of interest and no financial disclosures. The aim was to enumerate the outcomes and management of intraocular and intraorbital foreign bodies in some challenging scenarios. The first case was a 12-year-old boy who presented with a history of foreign body entering the eye when he was fishing. His visual acuity in the affected eye was counting fingers close to the face. And the anterior segment, this was the clinical image. So there was a fish hook with an entry wound and an exit wound. So the entry wound being at the 9 o'clock sclera medially, and inferiorly was the exit wound. There was no corneal tear, and the AC was formed. So we went ahead and took this patient up under general anesthesia, and we removed it using the advance and cut technique. So we cut the, at the entry wound, we cut the wound loop, the wire loop, and extracted it through the exit wound. And the cryotherapy was done in both the exit and the entry wound. The final post-op final visual outcome was about 6/12. That was the best corrected. This was the CT scan, and this was the first post-op day with a dense hyphema. The second case was a 61-year-old male who presented with a foreign body entering his eye at his workplace when he was trying to cut a wire. His presenting visual acuity of the right eye was perception of light was present and the projection of rays was inaccurate. And this was his clinical image. So he had a corneoscleral tear about 10 millimeters with a dense subconjunctival hemorrhage, and there was a iris prolapse. The AC was flat. The CT scan orbit was done, and that revealed an intraocular foreign body with an open globe. So he was taken up as a primary repair. This was the foreign body. It measured around 2.5 centimeters. With the globe contour was distorted. So the primary repair was the corneoscleral tear that was done under general anesthesia, and the secondary surgery was to remove the intraocular foreign body via the pars plana approach. But intraoperatively, we realized that it was a pretty large intraocular foreign body, and it was lodged into the posterior scleral wall. So it wasn't possible for us to take it out with just the pars plana vitrectomy. So we had to do an evisceration. This was the size of our intraocular metallic foreign body. The third case was a 31-year-old male who was brought in unconscious and disoriented. And it was an alleged history of a drunken brawl where he was stabbed in the left eye. The visual acuity could not be assessed, but there was a lid tear and we could see the dagger sticking out. That was the CT scan, which showed a sharp metallic radiodense object. And the tip of this was in the basitemporal lobe. The globe seemed intact, but there was a lot of, because it was a radiodense, we couldn't really make out. So we took this case up with the neurosurgery department, and they extracted the dagger through the craniotomy approach. And then we moved in and we realized that the globe surprisingly was intact. So there was no globe perforation. It was just a conjunctival tear, which we had to repair. But unfortunately, his GCS remained poor even post-op, and he was discharged against medical advice. The 41-year-old male was our fourth case who was referred actually from a neurosurgery, from a neuro hospital, where he was diagnosed with an intraocular foreign body. So his history was just, he was working in the field and a twig, went into his eyes, what he said. His presenting visual acuity was around counting fingers at 2 meters. So I don't have a clinical image, I'm sorry for this patient, but basically we couldn't see the foreign body, but he had a diffuse congestion medially, and he had a subconj hemorrhage also medially, and just temporal to the caruncle, he had a small tear. But we couldn't see any foreign body. Now, this was the CT scan that showed a radiolucent. So it was a hypodense foreign body that we saw, which extended from the orbit all the way medially, and it looked like the globe was intact. Okay, very quickly. Basically, we just took it out. This patient did well. His visual acuity was 6/60. This was our final results. 50% of them had good visual acuity. Yeah, I guess I'm out of time. So basically, I think we did well with 50% of our patients actually having a good visual outcome, meaning more than 6/60.
Subhashri.
Yes.
Have you, in the open globe injury, have you given the intravitreal injection at the end?
Yes. Yes. In all our in all our open globes, we do that.
Okay.
Yeah.
Wow, Subhashri, these were really
Very
crazy.
Yeah,
I
ominous.
know, yeah,
Yeah,
really
yeah.
ominous. But I think the fate and the destiny of a human being at
Yes.
the end of the day, and I think probably a lot of things. Imagine having such injuries and then coming
Yes.
out without any.
Absolutely, ma'am.
Yeah, so that's amazing, but very well documented. And I will,
Dagger
yeah,
picture is going to haunt me for a while.
yeah,
I'm
yeah,
sorry.
yeah. It's really gonna haunt me for a while
Yes, I'm
also.
sorry, ma'am.
After I think doing clean retinal surgeries, you don't want to see such things.
I'm very sorry for that.
No,
You can
that
all
was
take
very,
images.
very well put and very well documented. Yes.
Yeah. Thank you, ma'am.
How long do you have your follow-up for?
So for a couple of them, the dagger injury, actually, he was discharged against medical advice because he basically was systemically bad. His GCS was continuously low, so he underwent a tracheostomy, and then they couldn't bear the cost. So they were discharged against medical advice, and no follow-up. But the wooden stick, we followed him up, and he's still doing good. And the fish hook was doing good as well. He underwent a cataract surgery beyond that, and he's doing fine. And the eviscerated person is also fine. We've called him back after maybe the corona gets over for implantation.
So for
Rehabilitation.
patient, you didn't want to eviscerate in the primary setting?
No, so we still follow the primary repair, and then we still give them a chance because it gives the patient that much time to get him kind of accustomed to the fact that we're going to possibly, remove their eye, but we never do it as a primary sitting. We call them back. I mean,
What's the duration between your primary and your secondary?
within 3 days, 2 days.
Okay. Sure.
All right.
So it was mainly for medical legal purposes. Then anything else?
Yes, ma'am. And actually, we didn't think that the foreign body was lodged into the posterior scleral wall. So we still thought that it might be in the vitreous, maybe partially in the scleral, the posterior sclera. But this was completely like the whole foreign body was lodged into
In
the
2-3
sclera.
days when you go in again, there's so much
Yes.
information. The media is so hazy. So it kind of...
So we usually wait by the third day, I mean, this patient, the corneoscleral tear was just a little off the center if you seen the image. So in about 3 days, it wasn't too bad. Like we did the pars plana vitrectomy. Other than the fact that we just couldn't access the foreign body, we couldn't clasp it with anything, just wouldn't come out, wouldn't budge. So
Right.
then, unfortunately, we still had to go ahead with the
I think
evisceration.
your consent and counseling of patients
Yes.
is
Yeah, it's
important.
very important.
Yes, absolutely, ma'am.
And
Yes.
of course,
Especially.
explaining the risk of sympathetic ophthalmitis.
Yes, ma'am. Yes.
Yes.
So until his last follow-up, he didn't thankfully touch gold. Yes.
Sure.
Interesting.
Okay. Thank you, Subhashri. That was a very interesting presentation.
Thank you.